My topic today is robotic thyroidectomy better than endoscopic thyroidectomy. So going back to some basics, surgery is a common surgical procedure, and the oncological characteristic is that it is low growth, low recurrence, and good prognosis, which make the patient pay more attention to the quality of life, surgical outcomes after the operation, and also the functional recovery. And from the endoscopic to robotic era, the first endoscopic neck surgery was done in 1996, and next year there's the first report of endoscopic thyroidectomy. Since then, the various technique and approach has been described, and studies have shown that the endoscopic approach can provide us with better cosmesis, lower postoperative complication, and better completion rate than open surgery. However, as we know, endoscopic surgery is a technically demanding procedure because of the two-dimensional view, and also the instruments are straight and non-flexible, making it difficult to visualize surgical field and to manipulate the instrument. The robotic system has been developed to overcome the weak points of the endoscopic surgery, and it has been successfully applied to various disciplines, and especially in the urological situation where prostate cancer, now more than 70% of the prostatectomy is done under robotic system in the USA. And the technology has now been increasingly used in head and neck pathology. The first robotic thyroidectomy was done in 2007, and large-scale studies have subsequently concluded that it is a feasible, safe, and also effective method for thyroid surgery. So let's talk about the technical aspect of the robotic system. So it provides a three-dimensional surgical view. Also, there's a stable operating platform, including the operating arm, and also the camera is also very stable. It also provides free movement of the robotic arm in the surgical field. In addition to mimicking the surgeon's wrist, it provides tremor filtering system and motion scaling, and also dexterity of the human wrist. This enables the surgeon to access deep and narrow space as in the endoscopic thyroidectomy, which is very important when we need to complete a cervical lymph node dissection and to facilitate preservation of the parathyroid gland and also the recurrent nerve. Robotic surgery has been perceived as being more time-consuming because of the additional setup time in the robot, the draping of the robotic arms, the docking and undocking of the system, and also the exchange of the instrument, because it takes time for the system to register the arm for every exchange of the instrument. However, with gaining experience, this setup time can be markedly reduced. Another important aspect is the ergonomic. The surgeon can sit in the chair to operate the system, and whenever he gets tired, he can just rest, and the system can help the surgeon to hold the gland or the tissue by the system itself, and the surgeon can take a rest. This is particularly important when the operation time is long. Another important aspect is robotic arm can be used for retraction, and it provides provision of the traction and counter traction is important to obtain an optimal view for safe dissection, as we do in the open surgery. In the robotic system, the surgeon can operate 3 operating arms, and it also reduces unnecessary procedure sometimes, because as we have been doing endoscopic surgery before, and we need to retract the strap muscle, and sometimes we need to have a needle puncture for a suture to retract the strap muscle away. This kind of procedure may add to iatrogenic injury, and the surgeon can hold the gland by himself as retraction using the third robotic arm, which is not possible in the endoscopic surgery. This is a diagrammatic illustration showing the 3 operating arm holding the traction and counter traction, with the dissection in the middle using the robotic system. And in endoscopic thyroidectomy, surgeon can only operate 2 arms. Regarding the endoscopic thyroidectomy, the instruments are rigid, and surgeons are sometimes need to overcome limitation by their own physical efforts and also application of force. This kind of force may lead to iatrogenic injury, for example, a capsular rupture of the thyroid gland. Another thing is in endoscopic thyroidectomy, it depends on an assistant to hold the camera still for the vision. and sometimes it needs an assistant to grasp the gland and for retraction. It means it requires an experienced bedside surgeon. But in robotic system, we only depends on the surgeon operating on the console. So how about for thyroid cancer? So oncological outcome depends very much on the extent of lymph node dissection and also completeness of the gland removal. As we know, this is particularly important when we're talking about the thyroid surgery because there's a potential space is limited and narrow. There are some dead zones are invariably very difficult to assess using a strict instrument. For example, when we perform a substernal lymph node dissection. And in conventional endoscopic procedure, the surgeon, because they can only use two arms, it will take much more time and effort to perform a lymph node dissection when compared with a robotic system. And also in robotic system, the surgeon can perceive the depth and space in the surgical field more accurately because of the 3D vision and facilitate a more precise and meticulous dissection. The strong grasping of the gland in the endoscopic procedure, there may be chance of rupture of the thyroid capsule, and this may lead to the cancer slittling during the procedure. So I try to look into the literature about the surgical outcomes from these two procedures. So back in 2011, there's a comparative study with 96 endoscopic versus 163 robotic thyroidectomy. It is a gasless transaxillary approach. And they include the follicular neoplasm less than 5 centimeters and well-differentiated cancer less than 2 centimeters. And what they found is there are more total thyroidectomy and more central lymph node dissection in the robotic group. And more central lymph node were retrieved in the robotic group compared with the endoscopic group. And also they report a shorter operating time in the robotic group. So in the same year, there's a bigger trial comparing 580 robotic with 570 endoscopic procedure. It include patients with well-differentiated low-risk thyroid cancer less than 1 centimeters. So again, the same conclusion is the robotic system can have more central lymph node retrieve. And they also have a more central node metastasis and more advanced stage tumor in the robotic group. The complication rate were similar, and the completion rate were similar in both groups. So in the coming year, 2012, there's a multi-center trial with around 1,800 robotic thyroidectomy compared with 840 endoscopic procedure. So all patients have low-risk, well-differentiated thyroid cancer. There are more radical neck dissection in the robotic group. And again, they have the same conclusion that more central lymph node were retrieved in the robotic group. There were no difference in the surgical completeness in terms of postoperative serum thyroglobulin level. So it seems that the robotic thyroidectomy is able to perform better central lymph node dissection, but will it translate to an improved survival or disease-free survival for the patient? So a study published 2017 last year, it is a barbell approach with 480 endoscopic with 700 robotic system. They try to assess the disease-free survival after thyroidectomy, and they try to adjust the clinical pathological characteristic. And interestingly, they found that the robotic group have a longer operation time, and consistently, they found that the robotic group can perform more central lymph node resection. And there's, in this study, there's no difference in the 5-year recurrence-free survival. So how about the learning curve? So advantage of the robotic system is important because of the absence of a preformed space in endoscopic thyroidectomy. And the first reported learning curve for endoscopic thyroidectomy is around 40 to 45 operations. And later on, a multi-center trial evaluated the robotic thyroidectomy with neck dissection. these surgeons have previous experience in endoscopic thyroidectomy, and what they found is that around 50 cases of total thyroidectomy is required to acquire the learning curve for robotic surgery. How about the surgeon with no previous endoscopic experience in thyroidectomy? So this study assessed the learning curve for beginning surgeons with little or no experience in endoscopic surgery. They have performed 113 robotic thyroidectomy by 2 different surgeons. So here are the results, and what they found is around 20 to 26 cases is required to achieve the learning curve for a robotic system. However, in this trial, the number of surgeons enrolled are small and they have a short follow-up time. For endoscopic thyroidectomy, in general, the published number for the possible learning curve is around 60 cases, and which is around 20 cases more than the robotic system. And in this study, they have compared 96 endoscopic with 163 robotic thyroidectomy, and they found that the learning curve is consistently 20 cases more in the endoscopic group. So how about the quality of life after the surgery? Because we know that surgery has low morbidity. So in this trial, they try to assess, apart from the nerve palsy, they try to assess whether there's any pain, discomfort, swallowing difficulty, and also voice change after endoscopic and robotic thyroidectomy. In this study, they have 32 endoscopic with 53 robotic systems. It's a single surgeon experience. The assessment was done by post-operative symptom survey in an outpatient clinic by a dedicated nurse, and they have assessed the neck impairment index, the swallowing impairment index, and also the voice handicap index. But however, there is a significant difference in the interval between the 2 groups. So what they found is there are more neck discomfort in the robotic group, but there is less change in the voice in the robotic group. So they postulate that the increased incidence of neck discomfort in the robotic group is due to the longer operation time, wider flap dissection, and a larger dissection extent. But they found that the incidence of voice change and the voice handicap index in endoscopic group were significantly higher than in the robotic group. But there are some limitations of the small size study. There are some drawbacks of the robotic system. First of all, it does not have tactile sensation. Also, they do not have a tensile feedback to the surgeon. The time for exchange of the instrument is significantly longer than in the endoscopic procedure. And also, a open conversion is quite impossible with the robotic system. And the cost of the robot is consistently around 3 to 8 times more than the endoscopic approach, depending on the volume of the center. So here is a summary of the 2 approach. The robotic system have a 3D with magnification, they have a steady vision and also retraction, 3-arm operation. The procedure can be done by a single surgeon, but there's no tactile feedback, longer time for instrument exchange. It can provide more central lymph node dissection, but the complication rate was similar. It has a shorter learning curve and a higher cost. So at this moment, we can say the robotic surgery could overcome some of the technical limitation with the conventional endoscopic thyroidectomy. And studies have shown that they have increased lymph node retrieval in the robotic group. But whether this will translate into long-term prognosis, better prognosis is still missing data. Thank you.